Hello, dear friends and colleagues. Today, according to the plan, we have an analysis of two patients with vertebral displacement, but with completely different complaints, completely different anamnesis and, accordingly, completely different treatment tactics. Let's start with the first patient. This is a mature man with complaints of pain in the buttock, which passes to the anterior outer surface of the thigh. He has been ill for 2 weeks. In dynamics, the pain in the leg increases, it gets worse and worse, it's hard to step on the foot, the leg pulls like a string. He notes a burning sensation, a cookie in this leg. On the recommendation of the doctor, I did an MRI of the lumbosacral spine. Let's see what's there. Here we have MRI, these are sagittal sections in the T2 mode, these are axial sections. Axial slices are a cross-section. The patient is lying on his back with his feet towards us. This is the right side, this is the left side. What do we see here? Well, let's say if we look here, then here we see a vertebra, a disc, a vertebra, a disc, yes. This is a dural bag, there are such black threads in it, dots are nerves. What do we see here? We see that the fourth lumbar vertebra has shifted somewhat anteriorly. Here such a step has been formed. We also see here that he has a herniated intervertebral disc. This is clearly visible from the right side. We see such a round thing, that is, it is a sequester with a coronal migration and compression of the fourth spinal root coming out here. The pain in his leg is radicular. On the MRI, we see the compression of the spine. This all corresponds to the clinical picture. Accordingly, we are sure that his pain is related to this. What tactics are possible here? Taking into account the fact that he has been ill for only 2 weeks, in fact, he has not been treated in any way, he needs to be prescribed medication first of all. These may be non-steroidal anti-inflammatory drugs. They are primarily aimed at relieving inflammation, edema, and relieving the so-called nociceptive pain. The transformation of a herniated disc is a mixed pain. It is nociceptive and neuropathic. Neuropathic is just the feeling that everything is stretched like a string, that burns, bakes. This is just related to mechanical pain with nerve pressure. Drugs from the gabapentinoid group help well from this. Let's say the drug gabapentin. It is prescribed in a good dosage, gradually the dose increases. This allows you to control the pain in the patient's leg. When the pain in the patient's leg is controlled, he can move around calmly. We recommend him to increase the walking distance, that is, to walk, thereby walking increases the delivery of nutrients to the injury area and he has a natural process of resorption of a herniated disc. According to their signaling characteristics, these are the soft sequesters that have formed in him, with a probability of more than 90% capable of so-called natural or spontaneous resorption. Therefore, this patient's prognosis is extremely favorable. All he needs to do is walk around for now, take medications, limit the load on bending, lifting weights, some sharp twisting. In general, there is no need to loosen up the lower back. Some physiotherapy procedures have no clear proven effect and, in general, are not shown to him now. There was also a suggestion about blockades. It is possible to block such a patient, provided that his pain is not controlled by medication, but for at least 2 weeks. If the pain is controlled, then in general the blockade is not shown and so everything is fine with the patient in dynamics should be getting better, and better, and better. Again, we are not talking about surgery now, because he does not have a gross neurological deficit, he only has pain. By itself, the displacement of the vertebra and herniated disc is not an indication for surgery. Now, at this stage of his illness, it is advisable to consider only conservative therapy. Our second patient is a 67-year-old woman who has complaints of leg pain, numbness in the legs and even such wadding, weakness in the legs that occur when walking short distances. That is, literally, she passes 20, 30, 40, 50 meters there, she becomes ill, because the pain increases, and not less weakness in her legs, she needs to sit down, bend forward. This all leads to the expansion of the spinal canal and it becomes easier for her. What is the problem with this patient? In this patient, we also see an MRI displacement of the fourth lumbar vertebra, but there is no hernia as such. There is such a small bulging fibrous ring here, but here special attention should be paid to the fact that we see the so-called spinal canal stenosis. Stenosis is a narrowing. Due to what it was formed? Well, firstly, due to the fact that when the vertebra shifts somewhat anteriorly, this in itself leads to a narrowing of this channel. In addition, we see here a pathological overgrowth of this yellow ligament. It is located behind the spinal canal in this structure called the yellow ligament. It has increased and presses on the nerves from behind. In addition, we see here such modified arcuate or intervertebral joints. The joints are normal. Here's a look at how they look. That is, they are of such a beautiful shape. There may be a small amount of liquid inside or there may not be any. That is, well, relatively normal ones are these joints. And you see, here is a fairly wide spinal canal. Yes, here we can measure it. It turns out the distance is well 15 millimeters, yes. Here they are, the nerves are all lying loose. And look at what is happening at this level. At this level, the spinal canal is significantly narrowed, the nerves are compressed here. If we measure it, then the distance here will be about 4.5 millimeters. We see that the nerves are compressed from the front by the vertebral body, by this fibrous ring, and from behind by the hypertrophied yellow ligament, by altered intervertebral joints, and therefore the nerves turn out to be clamped, compressed like this. Often, with such an MRI picture, the patient develops a syndrome of the so-called neurogenic intermittent claudication, which is what our patient describes. That is, the appearance of pain no less or weakness in the legs that occurs when walking for short distances. Accordingly, here the patient has been ill for 8 months, she has already tried various options for conservative therapy, nothing helps her. And accordingly, here we are already talking about surgical treatment. What is the essence of surgery? Fundamentally, 2 types of surgical intervention can be considered here, which are aimed at releasing these compressed nerves. They differ in that this entire structure is fixed with implants or only decompression is done. What does it depend on? This depends, first of all, on the presence or absence of signs of clinical and radiological instability in the patient. With the displacement of the vertebra of the first degree, it is not uncommon for neurosurgeons to offer surgery only to release the nerve without fixation. This is due to the fact that it is often enough to release the nerves, only to remove the hypertrophied yellow ligament, bite the joints a little. This is usually enough to make the nerves feel free, and this allows you to do without installing implants. The classical operation involves the removal of the yellow ligament, the removal of joints, the placement of the vertebra in place, that is, the reduction or path and the elimination of instability by stabilization. That is, the disc is removed, a cage is put in place of the disc and 4 screws are installed. This is generally a good operation. With this pathology, it is just the same shown and is, strictly speaking, the gold standard. However, this operation is considered quite large, it requires a longer rehabilitation period, more significant limitations, including carries greater risks and possible long-term consequences. Therefore, surgery is now following the path of minimal invasiveness. If it is possible not to fix it, it is usually not fixed. In order to decide whether she needs to have surgery with or without implants, first of all it is necessary to do an X-ray from the lumbar region with functional tests, that is, ask the patient to bend forward as much as possible and bend back as much as possible. This patient has done such a study, let's look at it. What do we see here? This is extension, and this is flexion. We see here that the patient has clearly increased the displacement of the vertebra. Compare here, where she was lying in the MRI, right? You see, if you measure the distance here, it's about 5 or 6 millimeters, but here, look, the patient bends, here, if you measure the distance, but it's at least twice as big. That is, we see that when the body position changes, when the patient lies on the MRI, her displacement is minimal, when she stands up, the displacement progresses significantly. That's when she unbends even in a standing position, and when she bends, it increases even more. That is, the patient has a clear X-ray instability, the displacement of the vertebra is quite pronounced. And even taking into account the fact that the patient has no clinical signs of instability, it is still more justified in this case to perform a classic operation with the installation of implants, with the stabilization of this segment, because without the installation of these implants, this situation may worsen or may even further predict. However, once again, there are often cases when the vertebra is slightly displaced and at the same time it is fixed, especially in elderly people, and it does not go further. And therefore, with such degenerative spondylolisthesis, it often happens that it is possible to do without the installation of implants, if this leaf is relatively stable. Dear friends, that's it. I hope it was interesting. If you have any questions, then write them in the comments, I will try to answer them. If you need some kind of consultation, the contacts will be listed in the description of this video. That's it, have a good day, goodbye.